I'm Derek Hall, and we're going to be discussing ultrasound-guided interventional procedures for the knee. I have no relevant disclosures for this lecture. I would like to mention that this presentation is not meant to be a comprehensive review of this topic. Our objective is to simply cover the core competencies as outlined in the AMSSM Recommended Sports Ultrasound Curriculum for Sports Medicine Fellowships. Our learning objectives will be to cover intra-articular injections, iliotibial band bursa injections, and Baker cyst aspiration. I should mention there are multiple different approaches to these procedures. I've listed the preferred approach and the one I feel you should be comfortable with. There may be certain clinical situations in which you have to use an alternate approach. The preferred approach for the intra-articular knee is with the patient positioned supine. I like the knee flexed about 20 degrees or so using a rolled up towel or some sort of bolster can be helpful. This will both allow for better visualization of the suprapatellar recess as well as allow for relaxation of the quadriceps, which is important for the injection. The transducer will be positioned in an anatomic transverse plane over the suprapatellar recess. Our needle orientation will be in plane, coming from a lateral to medial approach. Our target will be the suprapatellar recess. This is located between the quadriceps tendon and quadriceps fat pad and prefemoral fat pad. There is some variability depending upon where your transducer is. So it's important to recognize in this longitudinal view of the knee, here's the patella, this is the quadriceps tendon. Our quadriceps fat pad only extends a short distance proximally, whereas the prefemoral fat extends further. The suprapatellar recess then lies between. So if our transducer is placed in this position here, we will actually have two fat pads with the suprapatellar recess located between them. If our transducer is positioned slightly more proximal, then we may just have the quadriceps tendon with the suprapatellar recess and the prefemoral fat below, as we can see in this image here. So it's important to recognize where your transducer is placed in relation so that you know how many fat pads to be expecting, and if your needle should really be oriented just below the quad tendon or below the quadriceps fat pad. One of the ways to ensure visualization of this space if there's not an effusion is with medial and lateral mobilization of the fat. And so in this short axis view of the quadriceps tendon here, we see that we're just taking our finger and pushing over the lateral aspect of the knee. And what that does is it differentially moves the fat, and we can really appreciate the plane of the suprapatellar recess quite well. So this is a very useful maneuver to use, particularly in those without a knee effusion. I prefer a 25 gauge 2-inch needle here. You can certainly use a slightly larger needle. Rarely do you require a longer needle, but there may be some occasions in very large patients where you need to use a 3.5-inch needle. Injectate volume can be variable. I prefer 4 to 6 mLs. For your transducer, you should use a high-frequency linear transducer. In most all cases, there may be some very obese patients who require a lower frequency curvilinear transducer, but this is not typical. The iliotibial band bursa injection is performed with the patient in a side-lying position with their knee flexed approximately 20 degrees. The transducer is positioned in an anatomic transverse view over the lateral femoral condyle. Your needle orientation will be in plane, moving from a posterior to an anterior direction. Your target will be the iliotibial band bursa, and this is located between the iliotibial band itself superficially and the lateral femoral condyle deep. There are some nuances to that really, so there is a lateral joint recess of the knee that lies at the most deep layer just above the lateral femoral condyle, and there is a separate bursal region that will lie above that underneath of the IT band. As we can see in our video here, as our needle comes in, I like to advance the needle through and advance it in an anterior direction to ensure that we get good injectate spread all under the IT band, far anterior as well. Sometimes in chronic cases of bursitis here, we may see some effusion or some adhesion within this area, and I do think there may be some therapeutic benefit simply from opening this area up with our injectate. Needle here is a 25 gauge 2-inch. Typically, this is a superficial injection, so you typically do not require any longer needle. Injectate volume can be variable, but 3 to 6 mLs, depending upon how much distension you feel you need to get, how adhesed that bursa level may be. A high-frequency transducer is adequate here for all patients due to the superficial location. You want to identify the common fibular nerve. Very rarely is it in play, but you are coming from a posterior approach, and that's the main structure that you would want to identify to ensure that it is not within your needle path. And as I mentioned, the lateral joint recess does extend out here, and so in this bottom image, this is a long axis view of the iliotibial band inserting onto Gerdy's tubercle, and we can see this knee effusion extending up towards the lateral recess, and so you can appreciate this is a knee effusion, and this is going to be the plane of an iliotibial band bursitis, and so this is the bursal layer directly underneath of the ITB. And then we can appreciate this layer here is actually a small amount of fluid that's tracking down into within the knee joint. And so this is the lateral joint recess here, and then this would be your iliotibial band bursa at this location here. So we're really trying to target this upper structure for this patient. Lastly, we'll discuss aspiration of cyst, and in particular a Baker cyst. When looking at cyst in general, there's typically 2 types of cyst you'll be dealing with ultrasound. Those are ganglion cyst and then cysts associated with fibrocartilage tears such as perimeniscal cyst or paralabral cyst. These images here are 2 very characteristic images of wrist ganglia that you may see quite commonly in clinic, and so often a anechoic or at least very hypoechoic, well-defined tissue that is really not compressible and has no Doppler flow within it. The fibrocartilage-associated cysts, such as this paralabral cyst of the hip, often have a slightly different course. They're usually a little bit more mixed in terms of echogenicity and may be variable in terms of the size of the surrounding cyst wall, and because of the communication with the joint, you can often see loose bodies or other things within these. This ganglion cyst fluid is typically very viscous, and so a 16 or 18 gauge needle is often required to achieve aspiration, and you may even need to use a lavaging technique, which we'll describe in a moment, to aid in your aspiration as well. From a clinical perspective, it is important to note that recurrence is not uncommon, and so I do counsel all patients on that prior to any procedure. The location of these cysts is often variable, and typically they will expand kind of via a path of least resistance, and so there's not a standard approach that can be mentioned for all of these cysts. You'll have to take a somewhat individualized approach based upon where the cyst is located and the surrounding important neurovasculature or other structures that you wish to avoid in the individual patients. In regards to a Baker cyst itself, prefer to have the patient in a prone position with the transducer in an anatomical sagittal plane over the knee. The needle orientation will be in plane, coming from inferior to superior typically. You can come in the opposite direction as well. I find this to be a little better tolerated by the patient. As mentioned, there is variability in cyst location, so you may need to take an entirely separate approach to what we're going to describe, but I would say this would be certainly the most common approach I would use in my clinic. Our target here will be the Baker cyst, which is located between the medial gastroc tendon and the semimembranosus tendon, as we can appreciate here. It's very important to ensure that the cyst is located at this typical location, and trying to identify the stalk communicating with the posterior knee joint, as we can see here. If you identify a cyst or other fluid collection that's not at this location, then that technically is not a Baker cyst, and I would be somewhat cautious in proceeding with an aspiration until you verify exactly what the structure is. As mentioned, these often can be somewhat viscous, and so you may need to use a larger gauge needle. Typically, I would not go with anything smaller than a 20 gauge. You may require up to a 16 gauge. Additional length of a 3.5 inch needle can be helpful here, particularly if there is a large cyst or if it's a multilobulated cyst. If it's a very simple cyst, a 2-inch needle may suffice. A high-frequency linear transducer is usually adequate in almost all patients unless the cyst has a very deep location, and on a large patient you may need to use a curvilinear transducer. You want to identify the popliteal neurovasculature. Typically the cyst will move superficial to that, so usually they're not in play, but you always want to ensure that you know where those structures are at all times. And slight knee flexion may help increase the conspicuity of the cyst if needed. As mentioned, multilobulated and complex cysts are not uncommon in the posterior knee, and these can become a bit more difficult to aspirate. As we can see in the image on the bottom here, there's a large loose body that's found its way into one part of the cyst with more of a typical anechoic region in the other lobe of the cyst here. This is just a very chronic cyst that has very thickened bursal walls and this internal debris and likely synovial hypertrophy. These can be challenging because this whole area here is likely all tissue, and so there's actually only a small amount of free fluid within this area. And one of the challenges of doing an aspiration on a cyst like this is that this free-floating tissue often will get sucked up into your needle tip, and it may require constant manipulation of that tip to get adequate removal of the fluid. And there may be times where the fluid is very thick, and if you're not having any luck with aspiration, you may need to consider a lavaging technique. And so for that, you can draw up normal saline and then inject that into the cyst and then aspirate back out. And we'll just continue in that manner until we're able to thin out the fluid enough that we're able to get adequate aspiration out of the cyst. That's our overview of our core knee procedures. Thank you.